I want to welcome all of our students here as well as our students from afar. In case anyone still is in the morning hours based on your time zone, good morning. Otherwise, it's good afternoon. Today's topic is the Integrated Osteopathic Physical Exam, and my name is Dr. Kelly Halma, and I'm on staff here at KCOM in the OMM department. So some of the learning objectives, we're going to review and demonstrate how to do this type of examination as a component of the standard of care physical exam or musculoskeletal exam. As always, we're going to review some of the components of osteopathic medicine, which include the tenets, the somatic dysfunction, some of the acute and chronic TART findings. We're going to go over contraindications as well as indications, primarily specializing or focusing on hospitalized patients, but apply otherwise. We're going to briefly talk about some of the documentation requirements. As we move into the ACGME environment, those are subject to change. We're going to have a discussion and demonstration of appropriate areas of treatment for specific diagnoses of patients here in our hospital based upon what some of our intern and residents were assigned as their patient, and we're going to go through and demonstrate what osteopathic areas they should be looking at, as well as treating their functions or their dysfunctions that I find when I bring them up here. All right, the osteopathic perspective, then the tenets. So remember, human body is a dynamic unit of function. It is self-healing. The structure and function, probably the most important component, is interrelated at all levels, and rational treatment is based upon these. Somatic dysfunction definition, you can never get away from. It's almost always in one way or another on your boards. So always at least spend 5 or 10 minutes reviewing those things before you walk in for those wonderful examinations we all look forward to. Tools you will look for. Always in the history, make sure you do a thorough examination of the chart before you proceed to treat in the consult. Your physical exam, integrate any laboratory or imaging findings that may be available before you step into the room. Think about your differential diagnosis, which relates more to your database, and investigate through different processes that you've been through before. Utilize your experience, think about things, and work through your attending. So here, this particular part, we're going to focus on the physical examination, a little bit of the history, using some examples, primarily focusing on some of the hospital components because they tend to be not as covered as much, and they're more relevant to the crowd I have today. All right, so the Integrated Osteopathic Neuromuscular Structural Exam within the standard of care exam as appropriate for the patient. So oftentimes you could do a full osteopathic examination, but not all of it is necessary. Let's keep it focused to the chief complaint or the reason we got consulted. The particular areas based upon the somatic dysfunction definition are as stated. The regions are stated. Remember, the head and the cervicals are two different regions. Those are important aspects when you're counting up the number of areas you've treated. So you want to target the highest areas that give us the best yield in relationship to the problem that you're treating primarily in the hospital. I can give examples that you would probably treat for a pneumonia patient: the cervicals, obviously the thoracics, ribs, the lumbar, and the sacrum, focusing on the somatic dysfunctions associated with the sympathetics, the parasympathetics, the regions that would be affected, as well as trying to optimize and normalize those regions. So, as always, we want you to make sure you do visual inspections. Let's think back to KCOM's acronym of HIPROT, which is the history, the inspection, physical exam, range of motion, other findings, and I'm forgetting one. What is it? Well, we'll find it later. So, all right, so the visual inspection of the spine, those are important areas that you'll be going through as all components as you do just an initial inspection and evaluation and physical exam of all your patients, and then your TART findings. So part of the current requirements is that you examine them in at least 2 positions. Obviously, that's not always possible, and so you document why. Either they didn't want to get up, when you woke them up at 2 o'clock in the morning to do another examination on them, or oftentimes they're on a ventilator or other particular problems preclude that other ability. Again, do your best. Indicate the somatic dysfunction related to the chief complaint. Unless, oftentimes, we may be consulted or you may be involved in a problem that's not related to their particular problem, such as a patient that comes in with pneumonia but has significant knee pain not related. You can also treat that because why? That significant knee pain may further exacerbate their ability to sleep or to rest and interfere with their ability to heal, and most importantly, be discharged in a timely and proper manner when they've reached their therapeutic levels. So sometimes you're treating stuff outside the box because it does benefit the patient. Yes, you wouldn't say that that's all connected, but you would also say that significant knee pain significantly is having them not maintain their highest level of being able to get out of that hospital and heal themselves, because that knee pain is keeping them awake, limiting their ability to get up and move, and affecting the other structures that are the reason they're in the hospital. All right, so again, we talk about the supine position if they're a respiratory failure and they're on a ventilator. All right, considerations. Examine, thinking about the functional units, the lungs, the diaphragm, the abdomen, the upper extremities. When we think about pneumonia, think about the requirement to return that patient to health. How do we get that diaphragm moving? How do we get those ribs moving? All those other particular areas. How do we down-regulate that fight or flight? That person is fighting for every breath, or wheezing, or gets to that point of short of breath, they're scared. And when you're scared, your fight or flight is elevated. So we need to normalize those thoracic regions or sympathetic regions and stimulate parasympathetic, which is your rest and digest. Progress from the least invasive to the most invasive. Try to work your way in, such as doming the diaphragm, gently elevating the ribs, getting the rib motion moving, particularly in an pneumonia patient. In a patient with post-op ileus or post-operative ileus, you want to be gentle, move, and the sacrum, get those particular areas. Avoid wherever the suture and the incision is when possible, and make sure that you try to mobilize the viscera in that particular area, as well as the other particular regions such as the upper lumbars, the thoracics, the cervicals. There's a lot of different things that we can do on that, and we hope to have a core competency lecture on that in addition to other hospital-specific complaints, but that will be another day. All right, so make sure it's efficient and meaningful. All right, so limitations and restrictions. Sometimes people just don't think they have enough time to do these things. I can assure you, if you think about these things, you integrate them, they'll be just as easy as you getting a review of systems. Once you get it down to the point that you won't even have to think about it. Much like many residents and interns are able to do a physical exam at 3 o'clock in the morning, have it all documented, and then when they are asked about it at 7 o'clock, they go, huh? Oh yeah, I think I remember doing that. But their skills are so well honed, it's almost muscle memory. So that's the area or the expertise or the proficiency or competency we want you to get to. So, all right, so general tips, watch out for anything in the bed. Don't pull out lines, watch where you're stepping. If you need assistance and the patient is in the bed, ask the nurses. Watch when you're raising the bed, because the second and most important thing when you're treating someone is to not cause yourself to have somatic dysfunctions. Excuse me. Integrate that particular exam into your normal process, and you'll always have that documentation complete, and you'll never have to go back and do it again. 4 or 5 minutes of your time, that's nothing. All right, so here we have some concepts. They present with a dysfunction, their condition, what would benefit from from OMT. The primary goal, again, is to return them to health and optimal functions, and obviously the benefit of that is that we've kept them out of a hospital when they're no longer sick enough to justify being here. It's a great place to be. when you're sick. When you're not sick, you're subjecting them to things that they don't need to get subjected to. Also, the costs associated with extended stays, particularly with small bowel illness, one of the most leading cause of extended hospital stays, involving $2 billion, and that's the short end. It's highly underestimated, but that's a particular area where osteopathy can make a tremendous benefit and save money. So appropriate frequency, you don't want to go in there and treat them too often, but you want to make sure you treat them enough, and that comes with, obviously, experience. So the duration, you want to make sure that they're continuing to improve, but also at the certain time, like when a patient gets moved over to the swing area, when they're in acute care and they get redesignated as a swing patient, we usually back down our treatments to every other day, primarily for the cases that they've already made improvements. You know, continuing to see them every day may not necessarily bring benefit to dysfunction, but like everything else, and sometimes the way we look at osteopathy is that we keep the ball rolling. Sometimes a ball is rolling, but sometimes you got to touch it. You got to keep it moving. You got to push it a little bit along to keep that momentum moving. Subsequent treatments are based upon whether you think they need it or not. Again, we want them to reach the maximum improvement, particularly the rib cage stiffness and pneumonia or acute MI. Remember, sometimes there's a difference between chest pain and chest wall pain. Both can be very scary if you're having them and you're the patient, and you want to make sure it's not an acute MI. But once you've ruled that out, it still hurts, and it still needs to be treated. Abdominal distension due to ileus or constipation, leading cause of why they can't leave. Remember, a patient has to be able to pass gas or solids through the rectum, obviously, before they're actually allowed to leave, because we don't want them to come back for the same problem. Again, low back pain, sacral pain due to labor, we get a lot of consultations for that. In addition to probably the jewel in the crown, being able to do cranial osteopathy on newborns. But that's a whole nother topic. All right, so indications, somatic dysfunctions, pain or chronic pain. Remember I talked about someone may come in with pneumonia but have knee pain? That may be a chronic knee pain, but it still affects their ability to get well sooner. So by treating that, letting them get a good night's sleep, letting them to ambulate, get up and move around, ultimately affects their ability to leave for the acute cause. Restrictive range of motion, atelectasis or associated with pneumonia. Obviously, probably one of the leading causes is ileuses, whether it's operative or not, constipation, abdominal distension. Lymphedema is probably an area that we can progress into. There's been somewhat of a pullback, if not locally, maybe nationally, in the lymphedema nurses. Again, we have a lot of people undergoing surgeries whose lymph nodes are being removed and they're having a lot of congestion, and we're not treating that as well as we could. Thank you. And also some of the anatomic. All right, contraindications. Obviously you want to be careful with cancer. You don't want to go over those particularly if it's spread to the bone. You don't want to be mobilizing or do aggressive treatments on that. Indirect is always good. Bone disorders, no high velocity. And then there's the vertebral arterial disease. Again, always have caution. The sicker the patient, the lesser the dose, the more frequency. So the sicker the patient, you want to be more gentle and see them more often, because they can't tolerate, aggressive treatments that we would do in the clinic. They won't be able to tolerate possibly HVLA. They may not be able to tolerate some articulation, but they would be able to tolerate some gentle myofascial release, or some soft tissue, or some balanced ligamentous tension, which may be the best thing because they're tight all over. Getting those areas in balance and letting those areas release may be the most significant thing, particularly if you're at junctional areas where we're playing switch. We'll go over that a little bit. Allow time to respond. We typically treat daily. And then oftentimes we come back depending upon the attending's availability. We'll go back and check on those, retreat those if necessary, but often just once a day. Don't overtreat. Get the ball rolling and get out of the way. Don't waste time on insignificant errors unless that insignificant errors, like the example of the knee, affects the overall area. Again, if that knee pain's keeping them up, they're not resting. If they're not resting, they may not get better as soon as we would like. So, TART findings, acute onset, often over the injuries, warm red, bogginess, increased muscle spasms or muscle tone, think of spraining an ankle, local inflammation, sharp cutting pain, increased sympathetics, because I don't want this to happen again, so I'm all hyped up. So, however, the chronic particular thing is long-standing, cool, more pale, skin scaling, particularly in elderly people with lymphadenopathy or peripheral vascular disease, check their big toes. If they're thick and scaly, that may particularly be a problem associated with other problems, but also has those type of findings, particularly the scaly skin. Chronic tissue texture changes, again, ropey, thick, particularly along paraspinal muscles you'll find. Chronic pain is not so acute as in painful, but sore, achy, a deep pain that doesn't seem to go away. A lot of increased sympathetic and some viscerosomatic response. Often referred pain, particularly people with stomach problems, IBS, Crohn's disease, other particular problems. You'll find more of a referral pattern that now they've got back pain that keys back to that area or refers back to the area, but they've also got the primary problem of the IBS or other particular problems associated in the abdomen. So you've got this vicious, I'm sorry, let me get a drink here so I can pronounce that correctly. Vicious loop of pain and feedback that you at least in one area you can possibly break and medically you can possibly treat. So don't ever forget that. All right, so again, we talk about the facilitation. That's that vicious loop process where the organ is hyperstimulated and the viscera, or the vertebral sections relating back or referring to that particular area are also hyperstimulated. So now you've got it going at both ends. And here's the classic example of that. So local viscera stim to that particular segment. That segment is also sending pain or activity back, hyperstimulating that particular viscera. By treating the somatic dysfunction in the thoracics, you could at least cut down one of the arcs of that. It's all connected. So think about the different pain patterns, esophageal, those particular areas. They're often classic, but never be afraid to think outside of a box. If it looks like they're having a gallbladder or a kidney stone, you think they're having a kidney stone, it's better to run a test that proves it's negative than for you to go home knowing that, oh, I wish I would have done that, and it turns out to be a kidney stone. I've had that happen before. It just felt like it. Still, you have to justify your tests and your examinations, but oftentimes your gut feeling or intuition is a very important part of the art of medicine. All right, somatic dysfunction, remember the OA and obviously the cranial effect or findings. The AA and the cervicals, thoracic inlets, the rotational components versus the other three-dimensional components, rib raising, and ribs, the bucket handle, the clavicles, and the sternum and the neurobium. Somebody help me with that? Thank you. Think about the thoracics, type 1 and type 2. Type 2s are more significant and more related to the facilitation. Abdomen, often restricted. Think about the quadrant. You're already examining the abdomen. You've already got your stethoscope on there. It doesn't take much more. You're already putting your hands on there, feeling for tenderness or rebound. So think about those particular areas, and we'll give an example of that here. The lumbars, the type 1s, and typically the type 2s are more associated with the somatic dysfunction or the chief complaint. The pelvis and the pubes, and the sacrum, probably one of the places that you want to utilize to restore function, particularly in small bowel ileuses. If you have any concern, we have vet gloves. I've ordered them. So if you have concerns about getting your hands underneath the sacrum, we have the long vet gloves if you need them. Upper extremities. So when we talk about pneumonia and other things like dysfunctions such as those, or rib cage associated with an MI, the upper extremities can restrict the upper ribs from moving. Think about the first rib. Think about those. If those particular areas are locked or not moving as effectively, they're not breathing, because the whole body moves in the breathing process. Not necessarily the elbows or the wrist, but the shoulders do. The hips, knees, legs, their ability to ambulate is also another sign of their ability to walk out of here, because some people don't have anyone at home and they have to walk to the restroom, and some houses are built with the restroom at the other end of the house. And so if they've got somatic dysfunction problems or knee problems, which we talked about with the pneumonia case, and they can't get to the restroom, you know, that commode that we're going to provide them with, it might get a little difficult when it gets fuller and they can't walk to the bathroom and empty it. So treating those particular areas, giving them that mobility in addition to the functionality of being able to do the common things you need to do at home, also gives them the ability to go outside, to ambulate, to continue to improve their gait and other things that are associated with improved health. Getting outside, walking. What's one of the first things they typically do in abdominal surgery? Yeah, they walk you, whether you want to or not. All right, so these are important areas. You will always see these on your board exams. Probably a good thing to condense the flashcards. I believe these are based upon the Foundations of Osteopathic Medicine 1 or 2, I'm sorry, 2 or 3. So another good thing to make sure you at least cover 5 minutes before you go into that exam, because if it's not a directly related question like this, it may be an order 2 or a higher order question that uses this to key you into something else. So typically on board exams, we typically don't, you know, skirt the boundaries. In other words, we may not ask you about something that you know, is around the range of T5 or T6. We're going to stay in the middle where it's obvious what we're talking about, okay? So when you see those questions, it'll be in the middle someplace, like, you know, T1 through T4. We'll stick it at T2. So just so that it's not so gray area and you're thinking it's 2 things instead of 1. Oh, all right. All right, so again, let's think about how we're going to get into it to see a hospital patient. If they're in their bed, bed height. Remember, you don't want your back to hurt any more than their back is hurting, so raise the bed up. Make sure you watch and look at all the lines and lift it up, and then raise it up slightly, see what's moving, and see what could potentially be disconnected, like hoses, vents, IVs, lines, okay. And then also the patient's comfort, you know, whether the bed is up, the head is up too high, the legs are up, and also make sure that you maintain those, I call them puff puppies because it just sounds cooler, but those airbags they put on the feet to stop stasis. What's the real name for those? Louder? Pneumatic compression devices. I like puff puppies better, but you know, if I have to divine my own, that'll be what they are. So keep the nurses happy. They don't like you pulling out stuff. They may ask you to put it back in. All right, the osteopathic approach. Correct the articular and muscular dysfunction. Restore autonomic balance, which means you process and try to down-regulate the sympathetic, which is the fight, flight, and I'm scared and I'm going to die and something bad has happened and I can't breathe or my heart is stopping, and then balance or stimulate the rest and digest. You know, the thing that says, I'm going to be calm, we're going to get better. My vascular system is going to open up and allow all this medication to be dispersed correctly, versus the sympathetics. That's going to hold all that stuff in the vascular system. It's not going to let it out because it's thinking you're running from a bear. Balance the diaphragm and the fascial components. Maximize the abdominal diaphragm, because what does the diaphragm do? The negative pressure you need in the lungs. What does the negative pressure do? Helps circulation get back to the heart. Not going to ask you what the heart does. All right, so mobilizing lymph and venous return and fluids and encourage the coordinated functions. Yeah, the abdominal diaphragm does quite a bit for us. And when it's dysfunctional, it throws things off. All right, techniques and dosages should be carefully considered with each patient. You got a 70-year-old not going to tolerate HVLA, although some will ask. I would defer that to outpatients, or someone with a high temperature or high dosage compared to someone who's relatively healthy. So, think about it before you do it. Look at the patient. What will they tolerate? Everyone can tolerate balanced ligamentous tension. Everyone can tolerate myofascial release. And they'll tell you why you're treating them if that's too much. All right. Remove any points between the particular areas, any pressure significant to the constriction of the nervous system or the blood flow. Again, that's some of the other areas that you always want to address. Are there any restrictions? Are there any areas that are impeding the flow? Particularly the arterial, the lymphatics. Let's think about the order in the pulmonary problem. Lumbars, the sympathetics, ribs, being able to move and create that negative pressure. The diaphragm, being able to function that. The sternum, if the sternum is injured or has problems, or problems not related to the particular problem that were pre-existing that they have overcome through using axillary muscle usage. Much like a kid who has exhausted his muscles and now has a little bit of asthma. Anyway, so again, the head and the cervicals, your parasympathetics, the lumbars, and the sacrums. All right, so sympathetics, the appropriate level. So that chart can come in handy, and I believe you have some of that on some of your cards that are covered with plastic. Rib raising, probably one of the most important things. Paraspinal inhibition, just getting in there, feeling where it's tight, holding it until it's not tight. Pretty simplistic. So, the distant ganglia. Parasympathetics, again, condylar decompression. Occipital sutures, little easy things. You don't have to do a venous sinus release. You don't have to do those things that you learned once, but your proficiency may be a little laxing because you haven't done it in a while. Basic things, you can all do the sacral rocking or sacral inhibition. If you inhibit it, it eventually holds, finds a balance point, and starts moving again. So, direct versus indirect techniques. So, carry to the barrier, have them taking a deep breath, move it to where it wants to go as the process is going, and then move it to the next barrier and repeat until you get it either better or at least exhausted the ability for you to make improvement. Again, you're just getting the ball rolling. You're not having to fix everything. You'll be back tomorrow. Indirect techniques, probably one of the things you use the most, whereas balanced ligamentous tension, where you're finding that balance point. You're having the patient breathe, finding where that balance point moves to, focusing on there, and then when they have to breathe again, or follow the respirator if they're on a respirator, and see how it changes. Then before you start balanced ligament tension again, check to see where that new balance point is moved to, because it's not going to be in the same place because you've got an improvement. So always recheck, move to the point, and do it again. We talked about zinc planes. A lot of times those are the transitional areas that you need to look into. We don't ask you to memorize those or anything, but think about how these transition areas, particularly in the thoracics and the cervicals and the rib area, sometimes can be dysfunctional. Remember, the body is a big spring. As you walk, you build kinetic energy and then release it in order to walk. Redoming the diaphragm, direct techniques, indirect techniques, different ways of doing that. Obviously, we want to enhance the movement of the lymph and remove any restrictions associated with that, because the movement of the lymph helps us get the patient better. Enhance and eliminate airway secretions. We have the thoracic pump. You remember that one where we go, So, but you need to be careful with that. You don't want to do the fast release with someone with COPD. Pectoral traction is a good thing. Pedal pump is a lot easier because you don't have to move the bed out. So, a couple examples of that. Again, you want to make sure you're treating the whole system to maximum function. you know, the CV4 or just compression of that particular area can greatly benefit. So, all right, to find health, anyone can find disease, and that's true. Being able to find and assess health, seeing how things get better, you know, that's what your recheck is for, is seeing how you progress. You know, oftentimes we treat things, we follow up once, and we never really see the full resolution because why? They got better. We don't always need to see them. So oftentimes you have a unique opportunity that they're getting better faster than they're going to get released. All right, thank you, Dr. Douglas. Any questions? All right, so we're going to do a brief demonstration. Can I have a volunteer? Don't make me pick one. All right, come on down. Because in the Army, we always pick the people in the back.
You already whipped this one into shape, haven't you?
Probably so, but you know. All right, so go ahead and just sit down here facing this way, right here. Yes. All right, so if we're outpatient and we're thinking about how we're going to assess everything, you know, obviously you always start, you know, on the head and the neck. So, you know, we would have done all the different things associated with, you know, looking into ears, eyes, nose, mouth, but, and then I want you to turn this way. Yeah, so you can see it on the camera. So we would assess the OA. We got a good image. Okay, so we would assess the OA. We can do it this way. We can wait till they lay down or just assess it and see, briefly check the motion. So if they're already sitting up, just seeing, oh, does it like to go this way? It doesn't like to go this way. So we know that it can be side bent this way, and we know rotation and side bending goes the same way, and so we just see if it goes better when we flex it or when we extend it. And it doesn't like to extend, so therefore it's flexed. So those things. We're already patting the back. We can run our hands down the spine. Actually, just go ahead and turn all the way around. So normally I'd be standing over here. So just running our hand down the spine, feeling for any tissue texture changes, rib points. We can side bend, spring all the way down. I can assess, you know, ribs, first ribs, deep breath in and out, assessing that. I can assess usually, you know, just gently the side bending component of the thoracic inlet. I don't do a rotation because he's just going to move, but I can do flexion or extension. I can assess the clavicle, the AC joint, and whether the arms are protracted or retracted, because oftentimes when people come in too much, you know, their ability to breathe openly is impaired because they're bent over and their arms are brought in. It's almost like they're driving, or they're doing too many video games, or they're typing too much. And so that can impact. So the ability for you to bring those arms back, to treat those pectoralis muscles, which we talked about, the pectoral traction, also can benefit them. So go ahead and spin back around. No vertigo, I hope. So as I slide in, I can assess the the SC joint briefly, press on the sternum, and then assess the ribs. Deep breath in and out. All right, so, you know, and can I borrow a stethoscope? I was going to use my tie, but I go, oh wait, I bet there's a few people in here that have a stethoscope. So, deep breath in and out. Again. So as I'm already doing what I have to do, I'm assessing the rib motion. I can see it going up and down, you know, back and forth. I can see whether there's any asymmetry going on. So let's go ahead and have you lay on your back with your head up this way. Now, obviously, I would be skin to skin, right? Because that's how we do things, especially when you have to go to Conshohocken, some of the students here. All right, so I'm going to be listening to the abdomen. I would reveal the abdomen, covering up their privates. I'm listening. So once I've listened, now I'm going to do some gentle palpation. We teach them to do light palpation, then deep palpation. Well, here I'm thinking about my ganglia, the celiac, the lesser, and the greater. And so is that firm, is that tight? I'm reaching around here, feeling the ribs. Deep breath in and out. and seeing how the abdominal diaphragm is, back and forth like this. You know, I have to reach under and probably check the thoracics, but as I push down on my stethoscope to see if there's any rebound, because I'm thinking this patient might be faking, and if I push down here, they'll say ouch, but if I push down with the stethoscope and they think I'm listening, they may not respond. So, little things that you pick up as you go through if you're thinking it. You know, those are just little tricks of the trades. So, I can assess here, just back and forth, up and down, forth, up, down, see if there's any, see if they moan or have any dysfunctions. I'll lift here, kind of pull down, I'll push up, see if he has any complaints. Obviously, push down on the shoulders, see if he has complaints, because that gives me the opportunity to see if I have any rebound or other tenderness. So, briefly going through things, I've gone through and I've examined the OA, the cervicals, the thoracics, the lumbar, just briefly. I've done the ribs, the abdominal diaphragms, the upper and the lower extremities, just briefly. I'm screening to see if I find anything. If they say, oh, I have these other problems, I would have gotten some of it in the history or supplemented, just asking them if they had problems. So, pretty much got that far, and I've done it in how many minutes? Probably less than 5. Okay, so, all right, so that's part of that particular integrated exam that you can do rapidly. Okay, and so you have those particular functions. I've screened them. Now if I have to go back and get diagnoses, I can at a different time. I can either do it in a seated or laying down. Go ahead and lay down again. If they're laying down, my ability to accurately do it in all 3 planes may be limited. I don't have to diagnose in all 3 planes as we taught you in school. I can simply go underneath, say, oh yeah, that area is restricted. I can say, oh, it doesn't like the side bend, and just leave it at that particular point. You know, the sacrum, always a difficult thing to diagnose. Particularly in this position, you can just say which one of the barriers or which one of the bases or ILAs is restricted. And if you can tell whether it's anterior or posterior, that's fine. You have a finding. Okay? All right, so that's it for now. Who did I borrow this from? Now, this particular part of the exercise is related to you having the diagnosis that you're working on up on the floor, and you come up here. You tell me the diagnosis, I tell you what areas I would treat with that, and then I treat you. In the Army, we'd call this stump the chump. So, who's got a diagnosis in the hospital they want me to treat?
Post-operative ileus.
Yeah, well, you got to come up here. Is that what you got?
Oh. No, I don't have it.
Who's got, I want a real diagnosis that you got in the hospital. Oh, come on. Nobody's well... What?
I can't say postpartum, I don't have that.
But you already volunteered. Come on. I'm equal opportunity. Postpartum.
Postpartum. Okay.
Slide over here. So, all right, postpartum. So, what are some of the things that I'm thinking of? Well, the emotional somatic release part of it. So, what other areas could be bothering them? Obviously, they have just... So they've delivered. How long ago did the patient deliver?
Last night.
Last night. So, you know, C-section or vaginal?
Vaginal.
Vaginal. So, you know, so we have the sacrum, obviously the pelvis. Was it a complicated delivery?
Extremely.
We're talking about the patient. I just happen to be working on this gentleman as an example.
They needed forceps delivery, I'd say.
Okay, so, all right, so we're thinking about, you know, how long did she go through labor?
10 hours.
10 hours. So now her legs are going to be up in the stirrup. Her pelvis is going to be locked in particular position. You know, that sacrum is going to be immobile. The head was down?
Yes.
Okay, so, you know, you can think of those things and you can look at those particular areas and treat that and benefit that. You can also go ahead and look at the anxiety that she may have in the thoracic spine and try to mobilize or stimulate the parasympathetics. So, all right, so go ahead and lay down on your back. So obviously I would look at the pelvis. So, and I don't have to, you know, when I'm looking for rotations or something like, I don't have to flip them over because that's kind of hard in the hospital. I can simply spring it forward. It doesn't like to go that way. It definitely doesn't like to go the other way, so I can assume it's anterior. I can bring him up. Go ahead and push your knee towards the end of the table and relax. I can assess the pubes. Obviously, you're going to be and make sure that they're aligned after delivery. You know, I'm sorry, I need to examine your pubes to make sure that their alignment and don't have any dysfunction. Is that okay?
That's okay.
Okay. I didn't ask him if he had equipment because theoretically he's a woman. There's a phrase when we examine men's pubes, we ask them if their equipment is out of the way or other kind ways. So if you don't use that at your site, that's kind of where we were leading with that. So, you know, I would check their knees, particularly the fibular head, because they're going to be more kind of up like this. The knees, the pubes. Check that out. Now I can just feel. There, roll back. And lift your head, take any deep breath, let it out. All right, so I've gone ahead and treated the sympathetics. I can either do sacral rocking, which would greatly benefit those. I'm actually going to have him roll over to better stimulate that, because since she's up and moving around, I can do that. Rocking chairs, lots of rocking chairs in OB. Put them in the rocking chair. That's a great benefit. Also, rocking chairs post-operative ileus, also an excellent opportunity. Just how you're going to get the rocking chair down there is your problem. I always tell people, make sure your bottom hand, your fingers are pointed north. So I'm just rocking back and forth. And then I would treat the paraspinals. All right. So that's probably as most I would do with that. I would ask her if she likes her neck treated. Do you like your neck treated?
Yes.
All right. Why don't you roll over? Obviously doing soft tissue. So now I've treated both areas of the parasympathetics. I've gotten the cervicals and I've got the sacrum. The sacrum was more restricted, obviously, because it's been slightly immobilized due to the passage of the head and everything else that goes with it. So that probably needs some more treatment afterwards. All right, thank you. All right, so do we have time for one more? What?
Yeah, I don't know if they have, we had one site look like maybe dropped out, so I don't know whether
Okay.
those are like this.
All right, who else has something in the hospital? What? Somebody? What?
The lingering.
What?
The lingering.
Oh yeah, come on up. Never had that one before, but what is this? Stump the chump. Slide over. So, where are you hurting?
Everywhere.
Everywhere. Any particular area that, you know, because we're kind of limited today, is there a really...
Everywhere. My head, my chest, my back, my entire body.
Okay. Is there anything that maybe you've gotten better with briefly before that we can try to get today and maybe, you know, come you back? What?
The dilaudid.
Yeah. And I understand that, and I'm sure that that takes away the edge so you're able to do activities, but right now I don't write for that. We'll have to return you to your primary care physician to deal with that. I primarily deal with the musculoskeletal component of that, so if there's any way you can help me to just, if we could do 1 or 2 areas a day, if you could just prioritize those, that would be probably most beneficial to you. Do you have a 2?
Okay, my upper back.
Your upper back. All right. What seems to be going on with that? Let's go ahead and turn all the way around. So it always hurts. All right, what makes it better or worse?
OMT makes it better, and so does dilaudid.
Okay, well that's good. Well, I'm glad that you have enough pain control that you're able to get out there and do things, because your ability to move and have enough pain management is essential, because if you didn't have that and you just did nothing, you'd be locked up, you know, like rust does to metal. Right there. Yeah. Well, how would you rate this pain right here?
9 on 10.
9 on 10. So, you know, well, I'm not going to do anything really aggressive because I don't want to stimulate other processes. So what I think I'll do is just do something really gentle, okay? I'll just have you just bend this way. Can you bend back, forward? All right. I want you to take in a deep breath. Let it all the way out. And then when you have to breathe again, just let me know. All right, so you had to breathe. I'm going to find that balance point again. We doing okay? All right, so take in a deep breath. Let it all the way out. And breathe when you have to. All right, very good. Obviously, I would do that another time. How's that now? Better, worse, or no different? No different? All right. So, you know, why don't you go ahead and lay on your tummy with your head this way. So, she's still got a tender point. I'm still assuming I'm not going directly to, what's that word?
Lingering.
Thank you. That's another word that I don't seem to be able to do really well on. So, I can treat it as though it's a tender point. So, I have her turn her head. I'd raise this particular area up. Oh, what did I do wrong? Did not establish a pain scale. Oh my goodness, I'm going to lose those points. So if this area right here, right where I'm pushing, nowhere else, this area right, if this is $1 worth of pain, okay, think about $1 worth of pain. I'm going to turn your head away. I'm going to bring this up. All right, so is that better, worse, or no different? $1.75. All right, so what about now? A little better? Like 50 cents? So how about now?
A nickel.
A nickel. All right. So I'm going to hold this there for about 90 seconds. I have a story that talks about the history of counter strain that I can tell, and it goes for about 90 seconds. They've quizzed me on that. I can assure you that that does go. I proved that once or twice, but I'm not interested in proving it today. So obviously I would hold it for 90 seconds, slowly return them to neutral. And this is one of the key things you got to say. You need to relax. You need to go limp. Just think of limp, 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 limp. Because I'm a doctor, you're a doctor. If you don't tell me to go limp, I'm going to help you. It doesn't matter how many years I've done this. I will help you. So you need to stop it. So tell me, limp, limp, limp. All right. So right there, how's that? Better, worse, or no different? A little better. Excellent, excellent. Well, why don't we get you set up with your primary care physician to get your dosage of Dilaudid, because I know that's important, and that will help you maintain even more activity because you're able to tolerate more activity when you have some pain control, all right? Okay. All right, so what was this example? So I dealt with a situation that could have been, you know, somebody coming in and they have pain. Or they're faking it much better than I think. It doesn't matter. I addressed the pain. She said it got better. I've turned her back to her primary care physician who will manage the pain or the pain medicine. And again, even all people in pain need something that they can tolerate so that they can have activity. By having that activity, they can move around. Moving around helps lessen that pain. That's been proven in fibromyalgia. You know, having enough pain control after a surgery, particularly a joint, knee, whatever, so that you can move, keeping that joint moving, which will eventually get better. So that kind of concludes what we're planning on today. We'll probably do this maybe 6 or 8 months later just as a refresher, and we'll update our slides and make it even better so that you can see or have a memory cue before we start. Again, my name is Dr. Kelly Halma. This is KCOM, and I want to thank you for your time and attention.